Good morning, everyone. Welcome to the American College of Rheumatology VIP Lecture Series. I am Mohamed Al-Fishawi, Rheumatology Fellow and a VCRC Vasculitis Fellow at Mayo Clinic Rheumatology in Rochester, Minnesota. I'll be moderating the first talk today about large vessel vasculitis. We'll start with a few housekeeping items. You will be muted throughout the webinar. If you have any technical issues, please use the raise hand function in the bottom and someone will assist you. If you have any questions to the speaker, please post them in the Q&A section of the chat box. After the Q&A section is over, you will have a 2-question survey to evaluate the lecture. The results are anonymous and will help guide further lectures. I'm honored to present our speaker today, Dr. Peter Grayson. Dr. Grayson is the principal investigator for the Vasculitis Translational Research Program at the National Institute of Health. He also serves as the acting program director for the NIAMS Rheumatology Fellowship Training Program. His talk will focus today on key issues in the clinical management of large vessel vasculitis. Dr. Grayson, the webinar is yours.
Thanks, Dr. Al-Fashani. It's a great pleasure to be with you today. And I'm going to tag team with Dr. Seo, who's going to talk to you about small vessel vasculitis. I have no relevant disclosures. These are the main learning objectives that were sent to you from the talk. And here's where I want to begin. So we're in an era in clinical medicine where access to non-invasive imaging is being increasingly utilized. And I'm sure you've been in situations where a patient who had difficult to decipher clinical manifestations was subject to a pan CT scan, so neck, chest, abdomen, pelvis. This is seemingly happening more frequently. And sometimes in these situations, and you will definitely encounter this during fellowship, there will be a finding of aortic pathology. Sometimes it's an incidental finding, not even related to the primary complaint, or other times it may directly be a relevant finding with what the patient's presenting with. So here's an example of that. This is a patient who underwent a CT scan with contrast and unexpectedly had profound wall thickening of the aorta, which is shown here in the red arrow. And when I first started fellowship, if I got consulted for a patient who had possible aortitis, my differential was rather small. I would think about aortitis, and I would think about maybe some infectious cause, and maybe I'd think about giant cell arteritis and Takayasu's arteritis, because those were the two forms of large vessel vasculitis that I was familiar with. But the first thing that I want to impress upon you is that there is a really interesting differential diagnosis for aortic pathology on imaging. And it's much longer than you may initially suspect. This isn't a complete differential by any means, but this is one that I kind of keep in my head just as a short list of things that I consider. And what you'll come to appreciate through fellowship is that some of these diseases are amazingly fascinating. There's really interesting things to find within this list. And one way to start to think about it is to understand this concept of aortitis versus periaortitis. So what does that mean? Aortitis is essentially inflammation that's transmural. It's involving all 3 layers of the aortic wall. And in contrast, periaortitis is inflammation that's outside of the aorta, perhaps extending into the adventitial layer, the outer layer of the aorta, but not really going full through all 3 layers of the aortic wall. And when you think about aortitis versus periaortitis, differential diagnosis starts to skew into different areas. And my point here isn't to go through each of these, it's just to give you the framework of these concepts. And I'm going to show you a couple examples of imaging findings that illustrate these points. The first thing I want to say is that if you get called for an imaging finding in the aorta in one of your patients, the move is to go down to radiology and look at the primary data. Look at the images with the radiologist. Don't just read the reports. And I think that's what separates an excellent rheumatology fellow from just a good one, is actually looking at primary data, looking at the biopsies that you ask for, directly reviewing them, looking at imaging, looking at x-rays, because there's so much information that you can glean when you get down into the details of what these images are showing us. So here's a case. This is a woman in her 50s who actually had elevated acute phase reactants and was imaged on that basis without much in the way of clinical symptoms. And what you're seeing here in the top picture is the abdominal aorta that's pretty much completely calcified. There's concentric calcification, and it extends all the way down in the bottom picture to those common iliac arteries, where you see that the walls are heavily calcified. But if you look really closely here, there's something even more interesting, which is that there's this hazy wall thickness that's outside of that calcified aortic wall. So this is one of the only examples that I know of where you can actually visualize periaortitis, because normally if you have a thickened wall, you're not sure if it's around the wall or involving the wall. But in this case, this patient had a calcified aorta, so you can really appreciate that this inflammatory hazy infiltrate is actually around the aorta. It's wrapping the aorta. And so when you start to think about this case, this is wall thickness with calcified abdominal aorta and calcified common iliac arteries. And it's suggesting a periaortitis. So a periaortitis that's in the abdominal and iliofemoral arteries predominantly, and this patient didn't have any other findings in any other vascular beds, should make you think about one diagnosis, and that is IgG4 related disease. So the point being that as you get better recognizing and understanding what you're seeing on these images, then you start to recognize the patterns, and then those patterns will direct you towards very specific diagnoses and really help inform your differential diagnosis. Here's another example of this. This is a problem that you will struggle with as a rheumatology fellow. This is a patient that has a large inflammatory mass enwrapping their abdominal aorta, encasing the iliacs as well. And you know that this mass is extending into the retroperitoneum, so causing retroperitoneal fibrosis, because the yellow arrow is showing you hydronephrosis of the kidney. So that right ureter is being encased by this inflammatory mass and constricted. This is idiopathic aortitis with retroperitoneal fibrosis. That is sort of the general terminology for this, but this could be a number of things. This could have been lymphoma. This could still be IgG4 related disease. And you will struggle as a rheumatology fellow with these cases of discussing, can I safely biopsy an area of this mass? Is it worth doing it? What's the sensitivity of biopsy? Am I just going to see scar? Am I going to see active infiltrate? Is this going to change management? And this will be discussions that you entertain on case-by-case basis. It turns out that this patient actually did have a biopsy that showed a predominant B-cell infiltrate with granulomatous inflammation. And IgG4 related disease is lymphoplasmacytic, not granulomatous. So this patient actually has a diagnosis that people refer to as chronic periaortitis. I just put this out there to say that as you go down this rabbit hole of looking at different forms of aortitis, you'll discover a lot of interesting different diseases that you've never heard about. And then go back to that first case, the first picture I showed you that you're getting consulted on for an abnormal imaging finding. And there's clues here if you look carefully. One clue is that this patient has profound wall thickness. So wall thickness in diseases like giant cell arteritis, when it involves the aorta, is usually around 2 to 3 millimeters. This is about 8 to 9 millimeters of wall thickness. So that should raise your antenna that there's something different going on. And although I didn't show you the full cuts, this wall thickness extends all the way down the descending aorta, encompassing the entire descending aorta. And it gives it this name, which is a coated aorta, because this aorta is completely coated in this thickened infiltrate. And there's no branch artery involvement. So unlike Takayasu's arteritis or even large vessel giant cell arteritis, there's no stenosing disease in any of the branches. This is really just confined to the aorta. So this patient actually, with that constellation of findings, has Erdheim-Chester disease, so a non-Langerhans histiocytosis. So those inflamed histiocytes are going in and causing profound wall thickness. And there's a whole host of other imaging findings that you'll learn are associated with this disease. So all of that to say, we've spent about 10 minutes or so talking about large vessel vasculitis, and I haven't even mentioned really in any great way Takayasu's arteritis and giant cell arteritis. So the first key point from this talk is that there is a lot of diseases out there, and it's really fun and interesting to learn about them and to think about them. So if you get called for a patient with aortic pathology, just remember the differential is quite longer than you expected. And as I mentioned, Dr. Seo is going to talk about small vessel vasculitis. It's really important to understand that these are very different processes, small vessel from large vessel, and very infrequently is there overlap between the two. So there's a set of diseases that skew one way versus the other. I'm going to talk to you a lot about vascular imaging and the role of vascular imaging, and I want you to understand that that pertains really only to large vessel vasculitis because scanner resolution isn't good enough to use these techniques in small vessel vasculitis. And really, we're going to dive into the two main ones, Takayasu's arteritis and giant cell arteritis. So Takayasu's arteritis is a disease of predominantly the young, although not necessarily, a 9-to-1 female preponderance. Its incidence is 1 per million, so it's a very rare disease, more prevalent in Asian countries, and really defined by involvement of the aorta and branch arteries. In contrast, on the other end of the spectrum is giant cell arteritis, a disease exclusively of adulthood, less strong female preponderance, the most common form of vasculitis in the West, with an incidence of 17 cases per 100,000, more prevalent in Northern European, Scandinavian countries, and historically thought to be a disease of the cranial arteries. You will start to learn that non-invasive imaging is pretty good these days. And with just an hour of scan time, we can do a 3-station MR angiography, which is what this picture is, and scan a patient from the carotid bifurcation down to the mid-thigh region, or the eyes to thighs, as it's sometimes referred to in radiology. And this will let you look at the entire aorta and its branch arteries in one setting to categorize and characterize the extent of disease. And here's an example of what Takayasu's arteritis can look like in its most extreme versions. It's a stenosing disease, and you can see here a high-grade stenosis of the left common carotid artery. That stenosis can become so profound that it causes complete occlusion. So this patient has occluded both the right and left subclavian arteries. So this patient would have no palpable radial pulses and no blood pressure in either arm. But in addition to the stenosing aspect of the disease, there are also, although less common, is an aneurysmal component, and this patient here has a pulmonary artery aneurysm. It's pretty well established that for Takayasu's, that imaging is really the thing that defines the disease, and it's important diagnostically. I think every patient with Takayasu's arteritis should have non-invasive angiography, and it really should be comprehensive, involving the neck all the way down through the pelvis so that you can characterize extent of disease. And this is what it looks like if you start imaging patients with Takayasu's arteritis. And these are 4 different patients with 4 completely different imaging patterns of disease. The first patient, really damaging destructive disease down the descending aorta. The second patient has symmetric disease, which is occlusive at the arch. The third patient has disease above and below the diaphragm. And the fourth patient just has focal disease only involving the left subclavian artery. And you'll start to learn that these patients, their symptoms are really dictated by where they have angiographic pathology. And that one patient with Takayasu can be very different from another. And in the lab and in the research level, we're trying to understand this clinical heterogeneity, because we think if we do that, this will inform precision medicine approaches, which are definitely needed in these kinds of diseases. In contrast, we historically think about giant cell arteritis as a disease of the head and neck region, and involvement of the temporal arteries, the facial arteries, the maxillary arteries lead to symptoms like headaches due to cranial ischemia, scalp tenderness, the same kind of process, jaw claudication, which is the most specific finding for giant cell arteritis, but it has to be asked correctly. And then the feared one of vision loss, which with involvement off of the branches of the carotid artery to the back of the eye. Temporal artery biopsy is the diagnostic gold standard for giant cell arteritis. And this is what you're looking for classically in a positive temporal artery. You'll notice many features on this biopsy. One is that There's this inflammatory infiltrate, these little blue dots of cells. These are mostly T cells and macrophages, often occurring in a bilayer here at the intimomedial junction and out here at the medial adventitial juncture. There are giant cells. These are multinucleated macrophages that often like to hang out right at the intimomedial border where the internal elastic lamina is. Very destructive cells, only present, however, in about 50% of temporal artery biopsies. There's inflammation out here in the small vessels, out in the vasa vasorum, and it's well described these days that vasculitis in temporal arteries and giant cell arteritis actually starts here. It starts outward and goes inward. So what is a large vessel vasculitis paradoxically actually starts out as a small vessel vasculitis. There's intimal hyperplasia. So this is the intima from here to here. This should only be a millimeter or so thick. This is definitely hypertrophied. And what happens is it compromises the lumen. And as that lumen gets more and more narrow, the patient will get symptoms of cranial ischemia, like frontotemporal headaches, for example. And here's fragmentation of the internal elastic lamina. What's the problem with temporal artery biopsy? Well, there are a number of things. One is timing it relative to glucocorticoids, the idea of skip lesions, and those are things we certainly talk about. But one of the more insidious problems of temporal artery biopsy is that there really isn't a histologic gold standard. And so you are going to encounter cases that look like this, where everybody can agree this is diagnostic for giant cell arteritis. But what happens if you have a case where there's only intimal hyperplasia, or there's only fragmentation of the internal elastic lamina, or only inflammation out in the vasa vasorum? Is that sufficient to be diagnostic for giant cell arteritis, recognizing that there are many mimics to that process, including atherosclerosis? And this problem is well exemplified in this study from 2016, where they actually took 14 different pathologists, and they gave them 30 temporal artery biopsies. And these were expert pathologists with experience diagnosing GCA. And in black were the number of times they thought the biopsy was negative for GCA, in green it's positive. And look out here in the middle, there are cases where there's a 50% disagreement, an even split. 7 pathologists say, yes, this is GCA, and the other 7 looking at the same biopsy say, no, it isn't GCA. So while we hold temporal artery biopsy as the diagnostic gold standard for the disease, there is definitely a subjective component to it. And it's really important, as I mentioned, to go review those biopsies directly with your pathologist, because you often in combination will see things that one of you may miss. And historically, the sensitivity of temporal artery biopsy positivity in cohorts of giant cell arteritis is declining. It used to be, 70, 80% of patients who had a diagnosis of GCA had a positive temporal artery biopsy. But in some of the more recent studies, that's been as low as less than 50%. So why is this happening? Well, one of the things is there's increasing likelihood that patients are being diagnosed clinically without a biopsy. And I think that this is a mistake. I think these patients, you should try to have histologic confirmation, or you have another option, which is vascular imaging, which we're going to get into in a minute. There's also been expansion of the phenotype to include large artery disease. And as I mentioned, we used to think about GCA as an exclusive cranial disease, but now we know, and we've known for decades actually, that a subset of patients with giant cell arteritis will have disease in the chest, abdomen, and pelvis, in many ways exactly like Takayasu's arteritis. And so patients with GCA can have both cranial and large vessel manifestations, just cranial or just large vessel. But this is the picture of the classic picture of large vessel GCA that you should burn into your mind. If a patient with GCA gets stenosing disease in the large arteries, this is usually what it looks like. These long stenoses that start in the more distal aspects of the subclavian and extend through the axillary artery. And you can see this patient's even developed really nice collaterals because this has been long-standing disease. In contrast, patients with Takayasu's tend to get more proximal disease. And not, more occlusive stenosis focal lesions than these long stenotic lesions. So this is a finding of large vessel GCA. It's a finding that you can easily pick up in the clinic because they will often have radial pulse and upper extremity blood pressure abnormalities, which I think you should do at every visit. Examine all of the pulses, blood pressures in all 4 extremities. You'll pick up things like this. You can even do auscultation of the axilla, and you'll hear bruits in many of these patients. They may think it's a little odd that you're listening to their armpit with your stethoscope, but it's worth it. And as we get into vascular ultrasound, this is actually an easily accessible area by ultrasound. So you can actually look at these wall morphology and stenosing abnormalities in these regions. So what are people doing nowadays? There's all these different options, and we're going to talk about different ways to diagnose GCA. But this is a study of around 1,000 patients with GCA. That's the largest international study in vasculitis conducted. It's conducted within a trial that's developing new classification criteria for these diseases. And what you can see is that the majority of patients with GCA in these expert centers are still getting a temporal artery biopsy, around 80%. But if you look here in Europe, it's around 70%. It's fewer patients that are getting a temporal artery biopsy. And why is that? Well, it's partly explained by the fact that in Europe, temporal artery ultrasounds have really taken off, and in many cases have become a surrogate to a biopsy, particularly in patients where there's a high index of suspicion. This hasn't happened as well in North America, and I think it's part of your task to bring us up to speed here, because there are centers an increasing number of centers in North America where they're starting to learn and to train fellows in how to do vascular ultrasound. So I would strongly encourage you to consider picking up this technique. And then here's large vessel imaging. This is angiography or PET scans. And you'll see that in these centers, about 50% of these patients were having some version of imaging. And when you add these percentages up, they're well over 100, which means that in the modern day, many patients for whom there's suspected giant cell arteritis are getting a combination of different diagnostic approaches, including ultrasound, other forms of imaging, and or temporal artery biopsy. So let's go through the menu of vascular imaging options. And I want to talk to you a little bit about the strengths and weaknesses of each of these approaches. And then I'll show you a case to kind of tell you how they all fit together. So as I mentioned, temporal artery ultrasound, very common practice in European centers now, coming to North America. And this is what you're looking for. This is a cross-sectional view and a longitudinal view of the temporal artery, where you see this hypoechoic rim around the lumen of the artery. This is called the halo sign. Here, seeing it in two different planes. And if you push down with the probe, you will be unable to compress away the temporal artery due to this thickened wall. So that's the compression sign. And the combination of the halo sign and the compression sign are felt to be rather specific for vasculitic involvement. Again, this isn't something that you can randomly do, just taking your ultrasound probe, sticking it on somebody's temporal artery. You really do need proper training in how to do this. And so I think North American centers have lagged behind Europe, and we need to catch up. The advantage of ultrasound is cost effective, no radiation. You can do it at the bedside. You can really get a lot of those areas that are affected by large vessel vasculitis, temporal, axillary, carotid, renal, iliofemoral arteries. And it has enabled a development of so-called fast track clinics where you rapidly refer a patient and quickly can ultrasound them and make a decision whether or not they need a temporal artery biopsy. And the advantage of such approaches is hopefully to minimize complications of GCA and to prevent blindness. The disadvantages of ultrasound are that it requires skill and training to perform and to interpret. You don't see the subclavian, vertebral, and aorta, some areas of the aorta as well. And these are key areas, particularly in Takayasu's arteritis. The role of ultrasound in longitudinal monitoring is not well defined, but we're starting to see research in that space. And if you look at it, it doesn't align very well with temporal artery findings in many studies. So many patients are positive by ultrasound, but negative by biopsy, or vice versa. And which one do you believe, and what should the real gold standard be? Okay, now let's go on to angiography. So traditionally, we used to perform catheter-based angiography, which is what this picture is showing, occlusion of the right common iliac and stenosis of the left. But nowadays, we almost never do catheter-based angiography for large vessel vasculitis because computed tomographic and magnetic resonance angiography, or CTA, MRA, are equivalent modalities. MRA is often preferred, particularly in younger populations, over CTA to avoid radiation. But these arteries are so large that either CTA or MRA is usually good enough to see them. That's a different story if you're looking for medium-sized arteries in the gut, where CTA is perhaps a bit more sensitive. We now only use catheter-based angiography, particularly in situations where a Takayasu's patient, for example, will have disease in all 4 extremities and we can't get a central artery pressure. So these are times when we use catheter-based angiography to measure central artery pressures. But by and large, non-invasive imaging is the way to go, because you're going to get everything you get from the MRA, from the catheter-based and more. So I'll show you some examples of it. This is an example of an MRA in a patient, and this allows for reconstructive images where you get these nice, beautiful 3D images, and you can visualize the patient's vasculature in a user-friendly way. So this is an MRA, and you're getting luminography. You're getting everything that you're going to get from catheter-based, but you also get a bit more. So when you order an imaging study for these patients, you will typically order an MRI/MRA. So this is the MRA. What is the MRI part? Well, those are vascular sequences that let us look at wall morphology, and this can be really, really helpful to you. So this is a stir signal, a T2 weighted signal, and you can see in this left common carotid artery what looks like a donut. So there's a thickened wall and it's bright white. That's edematous fluid. That's vascular edema. That's inflammation. And to us, this is what active vasculitis looks like on an MR. If you do a PET scan on this patient, for example, this artery will also light up in this area. So you're not only getting luminography, you're getting wall morphology, and both of those provide interesting and complementary information. There is high resolution scalp MR, so you can image those cranial arteries in great detail now. This is the temporal artery of a patient with giant cell arteritis, and you can see the wall thickening, the bright white fluid. The problem with high resolution scalp MRA is not many institutions have developed this capability, but it's coming, and you'll certainly see more about this at a research level. Here's computed tomography. If you recognize, this is the first picture I showed you. We're going to go back to it now and learn again. So what do we notice in this picture of where there's profound wall thickening? You also notice that the area is kind of hazy, light gray. That's referred to as contrast enhancement. That means there's retained contrast in the wall of that artery. That is the CT equivalent to suggest active inflammation or an active process. And this is a patient who definitely had ongoing active vasculitis in these areas. So angiography, we can define luminal damage. We can also assess wall morphology. We can profile the aorta and the branches. We can monitor progression of existing damage, monitor for new lesions. It can be technically challenging. Many centers have struggled with MRA. CTA is a little bit easier, but CTA has radiation. There's issues with contrast exposure with both of them. The FDA has a black box warning about gadolinium retention that can be retained in brain and bone for a year plus, and no one's quite sure if that has any clinical relevance, as well as the CT iodinated contrast eye issues. Cost and interpretation of wall morphology in particular takes skill, so having a good vascular radiologist is important. My favorite of the group is FDG PET scans, and we spend a lot of time at the NIH doing research on the role of FDG PET. And this is a classic giant cell arteritis finding on an FDG PET, where you're seeing profound FDG uptake throughout the entire large artery. So let me show you a little bit how to read these. What we're doing essentially is injecting radio-labeled sugar water, and that glucose is going to sites of metabolic activity. Here, your brain is red, so there's profound uptake because your brain uses glucose as its only energy source. So this patient is alive and thinking. And here we see excess radio tracer being excreted through the kidneys and out into the bladder. PET is so sensitive. It picks up so many things. For example, this is a patient's forearm muscle on the right hand. This is from signing the consent for the procedure right before the scan. It really, here's their AC joint, probably a little bit of AC osteoarthritis. But what we're interested in this case is the profound amount of uptake that's just outlining the subclavian, axillary arteries, the carotid arteries. This degree of uptake, to me, in my mind, is diagnostic for large vessel vasculitis. So how does FDG PET work? Well, we're giving sugar water, it comes in through glucose transporters, and it gets trapped after being metabolized to G6P. In cancer, and this is a PET scan showing lymphoma, the tumors switch from the Krebs cycle to glycolysis. So they prefer glucose as their quick, easy, dirty energy source. That's a phenomenon known as the Warburg effect. But the same thing happens in inflammation. Activated white blood cells also switch off the Krebs cycle and prefer glucose because it allows them to actually have effector function with much less energy requirements. And so we're taking advantage of the fact that immunometabolism is occurring, that white blood cells are using different energy sources. And actually, I think in the next 10 years, as you grow through training, we're going to start to target metabolism as a novel therapeutic in our diseases. The scanner resolution is getting better all the time, and this is a good example of that in PET CTs, where you can actually now, in the early iterations of PET CT, you couldn't see the cranial arteries, they were too small. But nowadays, with the time-of-flight reconstruction techniques, we can actually visualize the temporal arteries, the maxillary arteries, the facial arteries. And this is a patient with biopsy-proven giant cell arteritis from a study in Australia. And in the circle, you can see they have activity in the right temporal artery, as well as activity in both of those maxillary arteries. So PET scans provide a comprehensive assessment of vascular inflammation readout. This is actually not showing you damage to the wall, it's showing you inflammation in the wall. It's a complement to angiography. It can be used as a diagnostic test. It can be used to clarify unusual symptoms and even potentially to monitor treatment response. I'll show you an example of that. But it's costly. It has radiation. The nuclear medicine physicians aren't used to reading vascular PET. They need to learn how to do it. Steroids can blunt the signal like they do for every diagnostic test. Getting insurance approval is tricky, but it's getting easier. Medicare, Medicaid removed a clause that prevented reimbursement for use of PET for inflammation. And we're starting to see more and more people getting access to the technology. There's subclinical inflammation. Often patients will have PET activity and feel fine. And what do you do with that? And then longitudinal data is lacking, but it's starting to happen on the research level. So let me just take you through a case. The reason I want to show you this case is really to kind of teach you how these different imaging modalities work relative to each other. This is a patient that we saw at the NIH for research purposes. So the imaging that we got was really done for research. This isn't what you would normally do in standard of care, but it does let you see what each type of imaging provides as we're starting to diagnostically assess a patient. So this was a 69-year-old woman who came from a local hospital with suspected vasculitis. She was diagnosed with an inflammatory arthritis 5 years ago and treated with glucocorticoids and TNF inhibitor therapy. She did well for a number of years until she developed a rise in acute phase reactants, followed by left arm claudication, and was noted to have a decreased left radial pulse by her primary care physician. And by the time she came to us, she had subsequently developed claudication in her right arm. And when we really took a detailed review of systems, asking about those cranial symptoms of giant cell arteritis, the only thing she said was that she had chronic right-sided headaches that had been going on for years, and they were relatively non-specific and mild. On physical exam, there was reduced radial pulses bilaterally and a left subclavian bruit. Blood pressure was 111/68 in the right arm and unobtainable in the left arm, and her acute phase reactants were elevated. Now, this is a patient that you could consider large vessel vasculitis in. She's got vascular damage by exam. She has a good story for this. And this is a patient you potentially would consider a temporal artery biopsy, but she doesn't have a lot of cranial symptoms. She does have these chronic right-sided headaches. So I suppose if you were going to do a biopsy, you would biopsy her right temporal artery. She wasn't very keen on doing that and didn't want to have that procedure done. And it wasn't our top priority because she has vascular findings in her upper extremities. So we imaged her first, and that was our first approach. And this is her angiography. And you'll see that, she has a completely occluded left axillary artery, which is why there's no obtainable blood pressure on that arm, with the red arrow, and then the yellow arrow showing stenosis with post-stenotic dilatation on the right side. She has pretty ectatic, wavy looking vessels consistent with the fact that she's a bit older. And as I mentioned to you, bilateral subclavian axillary disease. This really is the pattern of a large vessel giant cell arteritis. One thing I want you to notice on this angiography is look at her carotid arteries. They're actually normal. There's not a stenosis, there's not an aneurysm. The lumen of her carotid arteries are normal. So if we just did MR angiography, this is what we would get. Well, what if we look at her disease in other ways? So this is CTA, and you can see a cross-sectional view through those common carotid arteries. Again, they're normal, they're not narrowed, and they're symmetrically normal. But you'll start to notice that she's got increased wall thickness around those carotid arteries, more so on the left than the right. Here is the same patient, an MR with a specific vascular sequence, that stir sequence, and you can see that she's got the donut sign. She has inflammation, what looks like inflammation radiographically on her left common carotid artery. Here's her PET scan, and you can see both carotid arteries actually showing pretty severe arterial FDG uptake, suggesting an inflammatory process. So by luminography, her carotids look normal because they're not stenosed. By CT, you see some wall thickness. By MR with dedicated sequences, you see vascular edema. And by PET, you see uptake. And this is her whole body PET scan. And she has that classic finding of a giant cell arteritis patient with profound uptake throughout the aorta, subclavian axillary arteries, and into both carotid arteries. As an aside, you may see PET scans shown in the literature in different ways. This is the same patient. This is just color filters. So people like to put different color filters on this. So that shouldn't hopefully confuse you. It's just the way to present the data. So we did not perform a temporal artery biopsy in this patient. We thought this imaging findings were sufficient to make a diagnosis of giant cell arteritis. And this patient was treated with tapered glucocorticoids and tocilizumab. And so what happens to her? What if you go back and image her a year later? What are you going to find? Well, this is her angiogram a year later. It's exactly the same as it was at presentation. This is a damage signal. We're looking at damage that is rarely reversible. So things look the same. Fortunately, she doesn't have any new areas of damage over this year. But if you look at her PET, it's much more dynamic. Here's her when we first saw her. Here's her 6 months later, and here's her a year out. So you see profound reduction in vascular arterial uptake, but it's still abnormal. And what if we met this patient for the first time a year later and did a PET scan on her? She's clinically asymptomatic, doing great, off of steroids, on tocilizumab. We would say, oh my goodness, there's still ongoing active disease. Do we need to treat this? And that's what we're struggling with right now at the research level. So here's the paradigm for how I think about what's happening in these patients with large vessel vasculitis. Early on, they have inflammation in their arteries. They may or may not have wall thickening. You know, here she has got inflammation in many different areas, but only had wall thickening in certain ones. They may or may not have edema. She has inflammation bilaterally in the carotids, but there was only edema in the left one. They may or may not be stenosis. There was stenosis in these arteries, not in these. As time goes by, things sort of start to abate a bit. And by the end, hopefully you've gotten rid of or controlled a bit the inflammation. It's usually still present to some degree. You're left with scar, which wall thickening can be an indication of prior disease. Hopefully you've gotten rid of edema or at least reduced it. And if you haven't done this in a timely fashion, you may be left with stenosis. And the thing that makes these patients so difficult clinically is that at any phase of this disease, they may or may not have symptoms. This stuff can happen silently and progressively, and that's the real challenge to the disease. But our goal with imaging is find them early when they're inflammatory and treat effectively to prevent stenotic complications. So I think the key thing for you to know is you got to personalize your approach. Know what your institution does well. Discuss this with your radiology and nuclear medicine department. Do they do MR very well, or do they prefer CT? If they do MR, do they have vascular sequences to look at morphology? Having these conversations can really improve their imaging techniques, and then directly reviewing your imaging studies with them. It's an iterative process. You both will learn together. I think you should acquire skills in ultrasound. I think you should consider imaging as a diagnostic surrogate in appropriate cases, high probability cases, cases where there's a contraindication to biopsy, cases where the biopsy is normal. And then monitoring patients match your imaging findings to the patient history, physical exam, and labs. And it's to this next point that I want to turn, because this, in my opinion, is the most important slide in my whole slide deck. This is the secret to managing patients with large vessel vasculitis. This is what has taken me 10 years to get at, and it's a no-brainer. So I guess I'm a slow learner, but this is the thing. When you're assessing these patients, what you're really trying to do is relate their symptoms to their vascular anatomy. And that's really the most important aspect of it. I'm gonna give you an example. When I see a patient with Takayasu's arteritis, I often ask them 3 questions. I think they're really important questions to ask. The first one I ask is, when you wake up in the morning and you first sit up on bed, do you get symptoms? And I specifically want to know, do they have lightheadedness when they rise from a supine position? And do they have vision loss? Because if those things are happening, it tells me that there's likely damage, stenosing damage in their carotid artery, because those types of symptoms are usually due to impaired baroreceptors in the carotids. And then I ask them about taking a shower. Do you get symptomatic in the shower? It's really important because it's a great test for arm claudication, because they're having to raise their arms above their head or above their shoulders for repetitive activity. It's an activity that they do almost daily or daily. And so they can track it. You know, I could wash my hair for 2 minutes, and now I can only wash my hair for 30 seconds, and I got to put my hands down, and then they rapidly recover. That is claudication. So it's really important. The other thing is, if you're washing your hair, do you start to get dizzy? Because that's a symptom of subclavian steel. So if I hear those types of symptoms, I start thinking about the subclavian arteries. I start thinking about the vertebral arteries and steel phenomena. And finally, I like to ask them, do they get symptoms when they're driving a car? Driving a car poses significant problems to patients with large vessel vasculitis, particularly Takayasu's arteritis, because they have to hold the steering wheel, which induces arm claudication. And as they do lateral rotation to check their blind spots when they're changing lanes, if there's vertebral artery pathology, they'll get vertigo type symptoms or vision changes. So that's the approach, is you're eliciting symptoms that correspond to specific vascular territories. And then when you're imaging these patients, you're looking in those specific territories and relating it back to their symptoms. That's the best way to take care of these patients, in my opinion. There are new guidelines that are put out by the American College of Rheumatology for the management of giant cell arteritis and Takayasu's arteritis. I won't go into great detail, but I'll just refer you there. If you don't know about the American College of Rheumatology website where all these guidelines are posted, you should learn about it. It's a tremendous resource to you. And I'll just touch on a few of them. One of them is, in patients with newly diagnosed GCA, we conditionally recommend using oral glucocorticoids with tocilizumab over oral glucocorticoids alone. It's a conditional recommendation because the level of evidence isn't enough to make it a strong recommendation. But this is a dialogue that you are going to have a lot in your fellowship, because this is an area of management that's evolving. Because of these 2 trials that showed efficacy of tocilizumab for GCA, it's now becoming more standard of care to treat patients with giant cell arteritis. And the discussions that you are going to have is, does everybody get it? Should we only get it if they're relapsing? Should we only get it if they're steroid averse? When do we start these medications, and in whom? These are great questions to have. And I guarantee you, where we end up at the end of your fellowship is going to be different than where we are now. And you'll also start to realize, what if tocilizumab doesn't work in these patients? Well, then you're out of luck, because you're quickly in a data-free zone. So we need better therapeutics. When you hear about ANCA-associated vasculitis in the next lecture, treatment has often become algorithmic. There's so much good evidence-based medicine to support what we do. We're not there yet in large vessel vasculitis, but the next 5 or 10 years, I think, are going to get us there. Here's another one. In patients with active Takayasu's, we conditionally recommend a non-glucocorticoid immunosuppressive agent plus glucocorticoids over glucocorticoids alone. There is this myth that large vessel vasculitis is a transient monophasic disease. Giant cell arteritis, Takayasu's arteritis can be treated just with glucocorticoid monotherapy. For a few months, taper them off and they do well. That's not true. Most patients with this disease have chronic disease, and often they're incurring substantial side effects and toxicities from glucocorticoids. So consideration of steroid-sparing therapies earlier in their management, I think, is really important. And then finally, you may go down this hole with some of the Takayasu's patients about surgical intervention, revascularization. And I just will put this in your head that many attempts at surgical correction of problems are unnecessary or even ill-advised. Here's a patient that had stenting of the right renal artery and in-stent stenosis, had to have another stent placed, constantly keeps having thrombotic complications with repeat angiography. So once you do a procedure in these patients, often you're opening up a whole host of problems. That being said, these are the times I think when surgical intervention may be necessary in Takayasu's arteritis. If you have critical disease of your neck arteries, this is a patient that had damage in 3 out of 4 neck arteries, was having recurrent TIAs, and ultimately got a aortocarotid bypass, which is what the arrows are showing. This is a graft. Refractory hypertension and renal failure, so not being well managed by medical therapies. Cardiac ischemia, critical organ damage. Most of the times, these patients, you leave them alone, you treat them medically, and they develop a collateral circulation. Sometimes that's not enough, and they have quality of life functional issues with blood flow to an extremity, for example. And so occasionally there can be intervention in that space, but you really do need to think about it extremely carefully. And last, I'll leave you, this is a PET scan of a patient with giant cell arteritis. These are super exciting times in large vessel vasculitis, and they're dynamic times. You're going to see so much change during your training and your early career as a rheumatologist in these diseases, and it's much needed. One of the other things that's coming down the pike is novel radio tracers for advanced molecular imaging. I showed you all the FDG, that's radio labeled sugar water, but what if we could radio label B cells and macrophages and get really immune cell specific and use that as an imaging surrogate for histology? This is all coming down the pike, it's all going to happen. I just can't wait to see what this talk is going to look like in a few years from now. So thanks for your attention.
Thank you so much, Dr. Grayson, for the wonderful talk. We have a bunch of questions from the attendees. We'll start with the first question. It mentions, I'm seeing a patient with a temporal artery biopsy proven GCA as an outpatient. Is there an imaging that I should empirically order to rule out other large vessel involvement, assuming the patient has no active symptoms? Or should it be symptom-driven imaging? And how does involvement of different large vessels change management?
Yeah, so you're breaking up a bit, but I think I got you. I think that in the current guidelines, there's a recommendation that every patient with giant cell arteritis should have imaging of the chest and abdomen to screen them for aortic aneurysms, which can be a feared complication of the disease. They're not very prescriptive in the guidelines as to what imaging to get. So I think this could be really institution specific, MRA, CTA, whatever your institution does well. But in general, it's a good idea to screen them for large vessel pathology beyond just exam. And every visit, you should be doing a peripheral pulse exam, checking blood pressures in all 4 extremities. It's amazing what you can pick up by doing that. But even that, a baseline screening image to make sure that the patient doesn't have an aneurysm, so that 5 years down the road, when a complication develops, you know if this is a new problem or an old one. And if they do have an aneurysm, then it would lead to serial monitoring. That's all we really do. If a patient with giant cell arteritis doesn't have large vessel imaging pathology on our screening image, we don't subsequently screen, we follow them clinically.
And would be any management change depending on the different vessel involvement?
Some people believe that large vessel giant cell arteritis is a little bit more difficult to treat, requires longer term glucocorticoids, and in the guidelines they even suggest doing steroid sparing therapy sooner for patients with large vessel involvement. Although I think that's going to change, because I think we're going to start using steroid sparing therapy for all comers in giant cell arteritis. It does It changes management in the sense that it lets you know what to look for with these patients, how to counsel them in terms of the symptoms they may experience, or what to look for if things get worse, and what to report to you. And some people believe that it is an indication to bump up your desire to put them on a steroid-sparing therapy.
And we have the second question from Ibrahim. It says, how many days the steroid therapy can affect the PET scan?
This is unclear. There was a study from the Dutch where they randomized patients with giant cell arteritis who had PET scan activity at the baseline image to be repeat image 3 days later or 10 days later. And they gave them 60 milligrams of daily prednisone every day in that interim. And the patients that were imaged 3 days later still all had convincing evidence of vasculitis on the repeat PET. The ones at 10 days, it dropped down to where, it was 4 or 5 of them only had imaging evidence of vasculitis. So they quickly lost signal. I think it's dependent on a lot of things. It's very idiosyncratic. Some of it is the nuance of how you're doing the PET images. The bottom line is that people suggest if you start a patient with glucocorticoids and you want to get a PET scan, you should do it ideally within 7 days. I do think there's value in doing it later in the course, but you just have to be careful in how you interpret it. Maybe you lose some sensitivity, but the specificity of PET would still be there. The same thing applies for every test when we're doing a diagnostic test in the setting of co-administering glucocorticoids.
Excellent. And then a third question, do you do interval imaging in patients with GCA in absence of symptoms? And if so, what imaging studies are you doing and how often do you do it?
No, for routine clinical purposes, we don't do routine interval imaging in patients with GCA if they don't have baseline pathology in their screening image. That's in contrast to Takayasu, where we are definitely doing routine imaging. For research, we are doing routine serial PET scans on giant cell arteritis, and we're trying to see if in a clinical trial setting, will PET scan function as an outcome measure? Can we use the PET scan to track whether a treatment is effective or not? And the preliminary data in that space is extremely promising. I do believe that we're going to start to see randomized controlled trials where the outcome measures aren't just the physician's subjective opinion of how the patient's doing, plus or minus acute phase reactants, but we're actually going to see imaging incorporated into those outcome measures. And I think it's going to make the trials better.
Thank you. And then we have a question. Do autoimmune vasculitis only affect arteries and no veins?
Yeah, so there are different forms of vasculitis that affect different arterial territories. Most of the time they skew towards the arterial side of things, but there's definitely venular inflammation that can occur. If you see a patient with inflammation of larger veins, that really should be a tell and a clue to suspect Behçet's disease, which is one of those diseases that's a variable vessel vasculitis. It can affect small, medium, and large arteries, and it can also affect veins. I bet venous inflammation is something that we underappreciate in our patients in general. But the clinical clue usually is if you see venulitis in a large vein, you should think about Behçet's.
Thank you. And we have a fourth question from Saud. In regards to IV pulsed steroids with visual symptoms defined as 500 to 1,000 milligram per day on the recent guidelines, what dose do you prefer?
Well, for me personally, I usually do a gram of steroids unless there's a patient is really steroid averse and smaller. Pulse dose steroids is one of these things that you're going to hear so much from. It's really good as a fellow to work with many different attendings, because you're going to find there are a lot of things where everybody does things differently, and start asking them questions. So why do you do that? Why do you tap the lateral side of the knee when the attending over here taps the medial side of the knee and insists that's the way to do it? And in no other arena is there more controversy and more stylistic difference than steroid dosing. So as a trainee, it's really great to see what different attendings do and to question them. And you'll quickly learn that the evidence behind what many of us do, it really isn't there. It's just a tradition that's been passed down from one person to the next. But if you start to look at the spectrum of clinical trials, we now have effective therapies for many of our diseases. Remission is becoming the expectation for many of our diseases. So what are we looking at next? We're trying to get more scientific with how we use glucocorticoids, and those are being incorporated into trial designs, which is really cool.
Very true. I agree so much with the stylistic approaches. And then we have another question. What kind of large vessel screening do you recommend, echo versus CT?
So if somebody I'm trying to look at pathology in the aorta or branch arteries, I prefer a non-invasive angiography, so either CTA or MRA. Our institute is very good at MRA, so that's my preference if a patient doesn't have a contraindication to MRA because you spare the patient of radiation. But we also have low radiation dose CTA protocols that we use. CTA is easier for most institutions to do, and so sometimes that's the fallback of what people do. If your institution is pretty good at MRA, though, that would be my preference.
And I have questions of my own. So in patients with atherosclerosis and especially older population, they might have some signals, although might be subtle in the aorta or the carotids and subclavians. How do you manage those patients if they don't have prominent GCA features?
Yeah, I think the first thing is to be humble that we can't really be confident in distinguishing vasculitis from atherosclerosis in many cases. Many cases of this gray borderline area. There are a few things that help me push me one way or the other. So vasculitic involvement tends to be above the diaphragm for most patients, whereas atherosclerotic disease tends to be below the diaphragm. Concentric disease that involves the entire wall all the way around is usually more vasculitic than sort of eccentric plaque-like lesions in atherosclerosis. Multiple areas of stenosis, the more areas that are involved, the more you think about vasculitis, the more symmetric the disease, the more you think about vasculitis. These smooth, long, tapered stenotic lesions make you think about vasculitis. But every time it is a struggle, and you have to really keep an open mind. We see many patients with large vessel vasculitis. When we look at their images, we think that some of these look like vasculitic to us and others look like more atherosclerotic lesions. The PET scan, unfortunately, doesn't help you as much as you think because atherosclerotic lesions have those inflammatory macrophages. They take up FDG, so there is activity. But in general, if you have really active vasculitis, it's usually orders of magnitude of our FDG uptake higher than the atherosclerotic ones. But there's certainly cases that can be really challenging.
Thank you. And we have another question in the chat. Is MRA/MRI with or without contrast?
So if we're going to do large vessel imaging, it's always with contrast. We do the MRA part has contrast. The MRI sequences don't require contrast. Those are looking at wall morphology. You can do what's called time of flight imaging where you actually don't have to give contrast, but that's pretty specialized, and we reserve that only to patients who have very severe contrast allergies. So if you're going to do a vascular imaging study, you really want to give contrast. The other thing I would point out is what's the difference between like a CT with contrast versus a CTA? And really the main difference is that you have extra sequence capabilities in the CTA, so you can do those reconstructions that you can't do with just a CT with contrast. So when I show you those 3D images of things spinning around, that's a CTA or an MRA. That wouldn't be an MR with contrast or a CT with contrast.
Okay. And the one last question. In your practice, if someone has cranial symptoms, do you go for one-sided or bilateral temporal artery biopsy from the get-go?
Yeah, so this is addressed in the guidelines where it's recommended that unilateral is preferred. You do have an incremental gain in sensitivity if you do bilateral, but oftentimes it's in my mind not justifiable. If a patient has localizing symptoms, then you biopsy the side where they're more symptomatic. Getting a good quality sample, I think, is more important than the unilateral bilateral. So making sure you're getting over a centimeter, but more like 2 to 3 centimeters, and making sure that if it's negative, that you go back with the pathologist and ask them to take deeper cuts and look deeper into the tissue. That's, I think, the most value. Sometimes we do bilateral, particularly if we have a patient that has large vessel alone and we really want histologic confirmation, and we're really kind of fishing, then maybe we'll end up doing a bilateral. But majority of time, if we do a temporary biopsy, it's unilateral.
All right. I think we're just about time. Thank you so much, Dr. Grayson, for the wonderful talk, and thanks to the audience for their questions. We'll hand it over to Dr. Kumar for the next session. You will get the survey now so that you can vote about the evaluation for the lecture. Thank you all.
Hello, hi everyone. Don't forget to answer the questions right there, and we're about to start the second half of our sessions for today. Again, thank you, Peter, Mohammed, and of course all of our participants for such a wonderful, engaging educational experience. We hope to maintain this level of excellence for the second hour. It's my distinct pleasure to moderate for the second session on small vessel vasculitis. My name is Bharat Kumar. I'm an associate rheumatology fellowship program director at the University of Iowa. More importantly, I'm here to introduce Dr. Phil Seo who is the director of both the Johns Hopkins Vasculitis Center and the Johns Hopkins Rheumatology Fellowship Training Program. He's currently a member of the ACR's Committee on Nominations and Awards and is the physician editor of the Rheumatologist. Thank you so much.
And thank you for inviting me to speak this morning. This is a great opportunity. I love nothing more than batting cleanup for Peter Grayson. So today I'm tasked with talking about the small vessel vasculitides. And in order to sort of set the stage for the next hour, what I wanted to do is give you a scenario. So this is it. Picture you're a first-year fellow. You are brand new to rheumatology and you've been assigned to the inpatient consult service. So you're sitting there in your office, you're ready to go, waiting for that first consult to come in, and there it is. And the consult says, patient admitted overnight, rule out vasculitis. That's it. So you call your attending and you give him a heads up as to what's going on, and he audibly rolls his eyes over the phone. And he says, just see the patient, get an H&P, and then when we're rounding, we'll figure out what to do with the patient. So that's what you do. You figure out who the patient is, you find out the room number where the patient's located. About 20 minutes later, you figure out where the building is, where the room number is applicable to, and then finally you walk into the patient's room. And you say who you are, why you're there, and you just ask, so what brings you into the hospital? And he just points a finger at his legs, and this is what you see. So Peter made a plug for looking at imaging studies, which I wholeheartedly agree with, because I think that you'll find that you get a lot more out of the evaluation if you're able to work with a radiologist closely. I'm going to make a second plug for taking a look at patients who've got interesting findings. So if you hear that the consult service admitted someone who has an interesting finding on physical examination, it's totally worth your time to spend 10 minutes to track down the patient and take a look for that patient yourself, because the ability to recognize these signs and symptoms is really going to help your career as a rheumatologist. So for example, in this patient's case, you walk into the room and you know that this patient has palpable purpura, which is the clinical diagnosis we associate with cutaneous leukocytoclastic vasculitis. That is a very long and complicated way of saying that this patient has a skin vasculitis. And you're thinking to yourself, well, that's kind of an odd reason for a patient to be admitted to the hospital, but you know, you're new here and you decide you're going to go with it. So you start asking the patient what happened, what brought on this vasculitis and what's been going on more recently. This is what they tell you. So the guy's a 28-year-old guy who was doing well until December when he developed this headache for the first time. And that's when things started falling apart, especially with his skin. He developed a rash that he described as flat red lesions on his legs. It lasted for a few weeks and then resolved with some hyperpigmentation. He continued to have monthly episodes and they started to spread. So now they're involving not only the lower extremities, but now the upper extremities as well, including the hands and the buttocks at this point. So you thank him for the information. You take a quick look at the rash just to make sure you've documented the distribution, and you go off to your computer and you start writing up your note. And you start writing things down like no drug allergies, one German Shepherd, name of scooter, drinks 4 beers a week. And you're writing all this stuff into your note. And then the attending stops by and you tell the attending exactly what I just told you. And the attending looks at you and says, the first thing I want to say is, you just did a great job. I love that presentation. You're giving me a chronology, so you gave me an idea of the progression of the illness. Maybe leave out the name of the dog the next time you present to me, but otherwise I thought that was just terrific. Here's the thing. I actually know the attending who is attending for this patient, and she already gave me a heads up that this patient isn't the most straightforward person when it comes to getting a history out of him. And she commented that there's a few more details that maybe we might have a hard time tracking down that are actually probably relevant to this patient's case. So the attending walked you through the information that the patient wasn't really interested in volunteering when you stopped by. So it turns out that headache of his has actually been around for longer than 6 months. It's actually been around for 2 years. And it's probably due to sinus disease. He's actually had a history of chronic sinusitis now that's been really hard to get under control. He's already been on antihistamines and antibiotics, and actually on a regular basis he receives steroids in order to bring his sinus pain under control, but the pain always comes back. About a year ago, he started complaining about joint pains. At first, he was treated with NSAIDs, but then gradually he started using steroids as well in order to get the joint pains under control. Now, from the patient's perspective, it's totally true that he thinks that he's here really for the rash because it's summertime, he wants to wear shorts, he doesn't like the way that kids sort of stare at his legs when he's walking on the beach. So for him, that's really his chief complaint. But another way to think about it is that the last 5 days, he's noticed he'd had this bad cough that he hasn't had before, and maybe that's what tipped him over to getting this evaluated now as opposed to, say, last month. So when he was in the ED, he got a CT scan of the chest, because why not? And in the ED, this is what they saw. So the first thing I got to say is that if you don't know who this patient is and you don't know their history, then you don't know how to interpret the CT scan. This could be a transplant patient with a CMV pneumonitis. This could be a hypersensitive pneumonitis. He could have raising pigeons at home for a living. He could be working on a kibbutz. This could be a lot of different things. But when you're a vasculitis guy, when you see a CT scan that looks like this, to me, this looks like blood. So while you're rapidly revising your note, let me tell you about what happened to this patient over the next week and a half while he was in the hospital. So they called for a pulmonary consult that agreed that this looked like it could be consistent with pulmonary hemorrhage, and they did a bronchoalveolar lavage that confirmed the presence of blood. They did a needle biopsy that was non-diagnostic, and they did some laboratory tests, including acute phase reactants that were elevated, and a ANCA test that was strongly positive. They did urinalysis that was significant for +3 protein and +3 blood. And when renal came by to spin down the urine, they noticed the presence of dysmorphic red blood cells. So as they say in the New England Journal of Medicine, a diagnostic procedure was performed, and this is what they saw. So for those of you who did not recently complete a fellowship in pathology, let me just show you what a normal kidney looks like in the inset. So this you recognize. This is a normal glomerular tuft. You see all this clear space surrounding the glomerular tuft where the urine is formed. This is a very happy kidney over here. This is our patient. You can barely see where the glomerular tuft was, and you can see the presence of a lot of scarring where there should have been normal tissue. And then over here, you can see this presence of this dark infiltrate that's consistent with the inflammatory cells that are now taking over his kidneys. So this patient has a crescentic glomerulonephritis that's also consistent with a small vessel vasculitis. So from this case, there are 2 important take-home messages. The first one is when you're on the consult service, the question the team asks you and the question you should be answering for them are often not the same thing. The second is that small vessel vasculitis is a lot like lupus. So you've heard a lot about lupus on Thursday last week, and you know now that lupus actually represents a broad spectrum of presentations. So some patients just have like a malar rash and discoid lesions. They basically have a skin disease, and they have lupus. Some patients have truly life-threatening illness that requires intubation and dialysis, and they're also listed as having lupus. So this is a large number of diagnoses as well for small vessel vasculitis that we need to consider. So I can't talk about each of these diagnoses in detail, but what I want to do is I want to give you a framework. So we're going to talk about 3 major topics. We're going to talk about what is vasculitis. We're going to talk specifically about what is small vessel vasculitis. And finally, what do you do when you see it? And I'm going to think of this framework sort of like something that you can hang information on as you learn more about these patients and as you see these patients in clinic and the consult service, just like you would hang ornaments on a Christmas tree. Now, I will say that I know that there's a broad spectrum of experience levels attending this lecture this morning. So although I'm going to try to give you a basic framework, if anyone has any questions about Pexavas or Avacopan, please bring them on. So first, let's talk about the basics. So what is vasculitis? And one of the main points of confusion, I think, comes from the fact that different specialists use the word vasculitis in different ways. So what a pathologist means when they say the word vasculitis is very different from what a rheumatologist means. So when a pathologist uses the word vasculitis, they're not actually bringing any judgment to the scene. They're just saying, I looked down on a slide and what I saw was evidence of blood vessel inflammation. So what does that mean? So typically it's going to mean they see one of two different things. They're going to see infiltration of the vessel wall with inflammatory cells, at first represented by elastic membrane disruption and diapedesis. Or they might see destruction of the vessel wall, represented by things like, oops, I'm sorry, I got this mixed up. Infiltration of the vessel wall is going to be things like diapedesis and leukocytoclasis, which indicates that there is neutrophil degranulation. So if you wonder where the phrase leukocytoclastic vasculitis comes from, that's the source. Destruction of the blood vessel wall is elastic membrane disruption, and then finally fibrinoid necrosis. So when you're thinking about the way that this predicts the manifestations of inflammation, you got to think about how the blood vessel is reacting to this process. So the blood vessel can react in one of two different ways. That blood vessel can either fight or it can give up. If the blood vessel decides to fight, what happens is that blood vessel wall is gradually reinforced with fibrotic tissue. And as that fibrotic tissue takes over the blood vessel, the lumen of that blood vessel starts to narrow. And you can just imagine what happens to the organ at the end of that blood vessel as that blood vessel swells shut. The second possibility is that blood vessel can give up. What happens is the blood vessel wall gradually loses integrity and gradually expands to form an aneurysm. And when the aneurysm finally can't hold on anymore, that aneurysm bursts open and releases the blood. That happens all the time in patients who have got palpable purpura. So what happens is that these patients have a leukocytoclastic vasculitis affecting the capillaries of the skin. And when these capillaries burst open, they release little blebs of red blood cells into the skin, which leads to what we recognize as palpable purpura. Not such a big deal when you're talking about the skin, a much bigger deal when you're talking about the aorta. But fortunately, most of these patients are diagnosed at a much earlier stage. So all this is what a pathologist means when they say the phrase vasculitis. What a rheumatologist means when we use the word vasculitis is we're talking about syndromes. We're talking about the syndromes that are characterized by the presence of blood vessel inflammation. So often when we're trying to make this distinction more clear, we'll use the phrase systemic vasculitides to refer to those syndromes, and vasculitis to refer to the pathologic findings. Now, the phrase systemic vasculitides is a big mouthful. So when you do this for a living, you'll find that we often don't waste that kind of time. So we often use the word vasculitis as a shorthand for those syndromes, which leads to a little bit of confusion when you're talking to people about these diagnoses, but you'll get used to it pretty fast. Back in the days of the giants, the way that vasculitis was classified was by looking at pathologic criteria, which was pretty useless. And the reason why it was useless is because most forms of vasculitis that we find interesting, they're characterized by granulomatous disease. So most of them are lumped into the same big category. The second problem is that pathology is often not available. People are unusually attached to the aortas, and when you tell them that you want to biopsy their aorta in order to come up with an appropriate diagnosis, you'll find that patients often hesitate a little bit. So it was the Chapel Hill group that decided that the way that we should think about patients with vasculitis is in terms of the blood vessel that's predominantly involved, which leads to the nomenclature you might have heard of already. So we talk about small, medium, and large vessel vasculitis. So when I was in training, I spent a lot of time looking at this particular diagram and trying to absorb all the information that it represents, because it actually does capture quite a bit of nuance when it comes to the classification of systemic vasculitis. But I think it almost represents too much information and makes it even a little bit harder to grasp the basics. So I'm going to suggest that you put this diagram in your back pocket, because it's going to be waiting for you when you're ready. And after you've seen some patients and you've thought about it a little bit more, I think that the diagram is going to make a lot more sense. But for right now, when you're starting out, all those details aren't completely necessary for you. So remember, when it comes to vasculitis, we're basically categorizing it in terms of the major blood vessel that's involved. So again, we're talking about large vessel vasculitis, medium vessel vasculitis, and small vessel vasculitis. Now, for those of you who are read ahead in the syllabus, you know that there are 2 additional categories of vasculitis that were recognized by the Chapel-Hill group. That includes variable vessel vasculitis and single organ vasculitis. Now, these represent special cases. And honestly, I'm going to tell you, don't spend too much time worrying about them because they're not going to come up a whole lot when it comes to making a diagnosis or treating these patients. But it does come up a little bit. So let's just talk about them just so you know what the categories are, and then we'll move on. So variable vessel vasculitis recognizes the fact that there are some forms of vasculitis that routinely affect multiple calibers of blood vessels, particularly large vessels and small vessels. Fortunately for us, that category only consists of 2 main diagnoses, namely Behçet disease and Cogan syndrome, and that's pretty much it. Single organ vasculitis recognizes the fact that there are some patients who have vasculitis that only affects one organ. Most commonly, that organ is going to be the skin. But other organs that can be involved include the brain and the aorta. I'll also mention as an aside that sometimes you'll find vasculitis affecting the genitourinary tract in isolation. And once in a while, you'll see a pulmonary mass that has vasculitis, even though vasculitis isn't anywhere else. So this does come up from time to time. But again, it's a pretty special case of more common forms of vasculitis. Getting back to the major categories of vasculitis, this leads to the obvious question. So what is a large vessel? And the answer is, as you just heard from Dr. Grayson, that the large vessels basically consist of what we call the aorta and the great vessels. So it consists of the aorta and the major branches off of the aorta. So you're thinking about the carotids, the subclavians, the axillaries, and the iliac arteries. And that's pretty much it. Those are basically all the large vessels. The medium vessels are the arteries that have a name outside of the great vessels. So you're thinking about arteries like the superior mesenteric, the inferior mesenteric, the celiac artery, the radial artery, and the ulnar artery. Any artery that's large enough to get an anatomic tag in your anatomy final that isn't one of the great vessels is probably a medium-sized blood vessel because it's large enough to have a muscular wall. Now, the small vessels are everything else. They're the capillaries, the arterioles, and the venules that bring blood to the end organs. Now, the reason why this classification system is so great is that once you have an idea of what category of vasculitis your patient has, you know what other manifestations you need to look for, just like Dr. Grayson was saying about large vessel vasculitis. So if you have a patient who has subclavian involvement, you know that you should also be thinking about the carotids, and you should also be thinking about the aorta, because that patient has a large vessel vasculitis. Similarly, if you have a patient who has involvement of the renal artery, you know that patient has a medium vessel vasculitis. So you should be looking for other territories that also have medium vessels, like the rest of the gut and the extremities. And finally, we come to small vessel vasculitis. So you're going to want to think about the areas that have the richest capillary beds. So remember, when you think about the vascular territories, they help you predict the clinical manifestations you might see in that particular patient. So a patient who has subclavian involvement, they're going to develop arm claudication when they use their arm on a repetitive basis. If they've got carotid involvement, that patient's going to be at risk for blindness and stroke. If that patient has aortic involvement, that patient might develop an aortic aneurysm, but the way that you'll pick it up clinically is you'll hear that aortic regurgitant murmur. With regards to the medium vessels in the arms and legs can lead to a mononeuritis multiplex that can manifest as a wrist drop or a foot drop. They can also create these large cutaneous ulcerations due to medium vessel ischemia. When the medium vessels in the gut are involved, these patients can develop mesenteric angina, which is pain after eating about an hour later. These patients can also develop other manifestations due to medium vessel involvement, such as digital ischemia. Finally, with regards to small vessel vasculitis, you're going to think about the areas that have the richest capillary beds. So for me, that's going to be 3 major territories, namely the the skin, the kidneys, and the lungs. So these are the patients who are going to develop palpable purpura, glomerulonephritis, and pulmonary hemorrhage. So we talked about some of the great things about this classification system. One is that it helps you determine the distribution of vessels that you should be looking for in any particular patient. The second, it helps predict the clinical manifestations that any particular patient might suffer. The other great thing about this classification system is it really helps you narrow down pretty rapidly what diagnosis you're looking for. So if you have a patient with large vessel manifestations, first and foremost, you're thinking about the two main diagnoses that we associate with large vessel vasculitis, namely giant cell arteritis and Takayasu's arteritis. Now, of course, there is that long list of other diagnoses you should consider, including Behçet disease and Cogan syndrome, but you should probably consider giant cell and Takayasu's first. If you have a patient who has a medium vessel vasculitis, especially one that's affecting the area of the gut, you're first and foremost going to want to think about polyarteritis nodosa. On the other hand, if you have a patient who has a medium vessel vasculitis that's affecting the arms and legs, you want to think about diagnoses like thromboangiitis obliterans, previously known as Berger's disease, and rheumatoid vasculitis. Finally, for small vessel vasculitis, for most of you, that's going to mean three diagnoses. It's going to mean granulomatosis with polyangiitis, or GPA, microscopic polyangiitis, or MPA, and eosinophilic granulomatosis with polyangiitis, or EGPA. And I'm telling you now, just practice saying this a lot of times. It doesn't get any easier. I will say that small vessel vasculitis also includes other diagnoses, some of which are listed in this slide, and include cryoglobulemic vasculitis, IgA vasculitis, and urticarial vasculitis. So today we're really focusing on small vessel vasculitis, and remember that we divided them in these two major groups. And the reason why they're divided in this way is because they kind of represent the two major categories of small vessel vasculitis. So GPA, MPA, and EGPA together are referred to as the ANCA-associated vasculitides. These are the diagnoses that can present with life-threatening disease, like pulmonary renal syndrome. So these are the patients that, by and large, are going to end up being on the inpatient side. Now, these other diagnoses, like cryo, IgA vasculitis, and urticarial vasculitis, these are referred to as the immune complex-mediated diseases. Now, these can be life-threatening, but they're often not. And because of that, you're often going to meet these patients on the outpatient side. Let's talk a little bit about the pulmonary renal syndromes. So remember that pulmonary hemorrhage by itself actually can occur commonly from things other than rheumatic disease. So you're going to think about things like malignancy and infection, bleeding diatheses. And the reason why rheumatologists generally don't talk about that is because no one knows this better than the NICU attending. So if that's what the patient has, they figured it out long before they would have consulted. The patients that we're really interested in are the patients with pulmonary renal syndrome, the patients who have both diffuse alveolar hemorrhage and glomerulonephritis together, because the majority of those patients probably will have a rheumatic disease. Now, the most common cause of pulmonary renal syndrome is going to be an ANCA-associated vasculitis. And one of those diagnoses, microscopic polyangiitis, actually accounts for about 1 out of every 4 patients that you might get consulted on in the NICU. That said, you should think about other diagnoses as well. And that includes things like anti-GBM disease, which is also known as Goodpasture's disease. Systemic lupus erythematosus is also on the list, not because SLE is a common cause of pulmonary renal syndrome, but lupus is such a common diagnosis that it's always worthwhile considering, at least in passing. I'd also say the same thing about cryovasculitis, that even though cryoglobulemic vasculitis doesn't commonly cause pulmonary renal syndrome, it certainly can. And it's common enough that it's also worth considering before you rule it out. Now, as Dr. Grayson alluded to, there are new criteria for the classification of the ANCA-associated vasculitides, which I'm showing on the screen. Unfortunately, it's one of those awful point systems where you have to look at your patients and add up a certain number of points. And if your patient gets to a certain total, that patient wins, sort of. Now, I will say that these classification criteria are new enough that you will probably be introducing your attendings to them. So it's important to remember that when you're talking to your attendings that they may not know these off the top of their heads. The other thing I'll tell you is that these criteria will make much more sense to you when you're actually meeting these patients in person. And the reason why I think the classification criteria are so useful is because they act like a checklist. They remind you what are the important things that you need to look for in terms of the lab tests or in terms of the patient evaluation that may help establish or refute a diagnosis of an ANCA-associated vasculitis. Now, that said, I know that a lot of you don't have a lot of experience seeing these diagnoses on a regular basis, so I wanted to try to make this a little bit simpler for you. And the first thing I'm going to say is that I'm just about to lie to you, but just a little bit, and I'm doing it for your own good. Because I'm using a model that's not going to explain every single patient that you might see in clinic or in the consult service, but will apply to the majority of patients. I think is a good way to keep all the factors that you need in mind. So remember that MPA, GPA, and EGPA all represent a family of diagnoses. And in this family, it's MPA that's the most simple. This is pretty much a straightforward disease of blood vessel inflammation. So the characteristics of MPA are basically what you could predict knowing where the blood vessels are going. So these are the patients who present with the pulmonary renal syndromes. They can also present from a sensory neuropathy because of involvement of the small vessels and small nerves in the skin. Once in a while, these patients can develop a mononeuritis multiplex, which is technically a medium vessel manifestation, but once in a while it can show up in MPA patients. And that's pretty much it. These other diagnoses, they're what I consider the vasculitis plus syndromes, because both of these diagnoses can do everything that microscopic polyangiitis can do, plus something else. Both these diagnoses have some extra feature that makes them unique. In the case of EGPA, that extra feature is going to be the presence of eosinophils. And that's the reason why patients with EGPA present with wheezing, because those eosinophils give those patients an eosinophilic asthma. They can also lead to chronic polyps in their sinuses and the fleeting pulmonary infiltrates that rheumatologists like to talk about when we're evaluating a patient with EGPA. These pulmonary infiltrates are often misdiagnosed as a walking or an atypical pneumonia, and it's not uncommon for these patients to have a history of receiving multiple courses of antibiotics before someone comes up with the right diagnosis. Whenever you evaluate a patient with an eosinophilic disorder, whether or not it's EGPA, you have to remember to think about the heart. Remember that eosinophils have a tropism for the heart and can cause pretty significant heart destruction. So these patients can present with a myocarditis or conduction abnormalities, and it's important to consider that first when you're thinking about an eosinophilic disorder. Now, for patients with GPA, that extra non-vasculitic feature is the presence of necrotizing granuloma. And the nice thing about this is that those necrotizing granuloma, by and large, hug the respiratory tract. So those necrotizing granuloma, if you think about the nose and you work your way all the way down to your lungs, and you think about what those granuloma are going to do if they just sit there for long enough and cause destruction, you can basically predict almost all the non-vasculitic manifestations of GPA. So let's go through that. So starting at the nose, you're going to get inflammation of the nasal septum. And if it sits there long enough, it's going to lead to a nasal septal perforation, just like you might associate with the Wall Street kids who snort cocaine. If that destruction is allowed to progress, those patients will eventually develop destruction of the nasal bridge. And those patients will develop a collapse that's known as a saddle nose deformity. Moving further back, you get to the sinuses, and patients who have granulomatous inflammation of the sinuses will present with chronic sinusitis. So it's not uncommon for these patients to have a history of having seen 3 allergists and 4 ENTs before they get to you. Because of the inflammation of the sinuses is connected to the eustachian tubes, these patients can develop eustachian tube dysfunction. So patients are going to complain about having hearing problems, but they're also going to note that they always feel like they've got a clog in their ear, like they can't get water out after a shower, or like they're coming off of an airplane ride. And it's because the eustachian tubes aren't able to open up and let those pressures equalize. Moving further down, they're going to get inflammation of the region just below the vocal cord, so in the subglottic region. So that subglottic inflammation will lead to an accumulation of scar tissue called subglottic stenosis. And the way that these patients will present is they'll tell you they think they've got a new diagnosis of asthma because they can't take in a deep breath. But what you're going to notice when you talk to these patients is these patients have developed a really interesting way of talking that I think of as a soliloquy pattern, because they know that the hardest thing for them to do is take a really deep breath. So they get used to talking really long sentences, and then they take this dramatic pause so they can take another deep breath and get the next sentence out. The other thing you're going to notice in these subglottic stenosis patients is they're going to have this little bit of a rasp, kind of like what I think of as a Darth Vader overtone to the way that they talk. And finally, moving down to the lungs, these patients are going to have these large lung masses that frankly look just like the lung masses that you might associate with, say, lung cancer or a fungal infection. And honestly, often you're going to need pathology in order to tell the difference. So let's go through a couple of pictures. So this patient has two different manifestations of GPA, only one of which you can see on the slide. So this patient has a saddle nose deformity, which you can see in the middle, and you can see why it's called a saddle nose, because if you picture this patient in profile, you can just imagine how dramatic that divot is going to look. The second manifestation that this patient has is an orbital pseudotumor, and this breaks the rule that I just told you about. This is one of the manifestations that doesn't track along the respiratory tract. But these patients can develop an inflammatory mass that sits behind the eye and pushes that eye forward. You would think the easiest way to diagnose a patient with an orbital pseudotumor is just to look at them and see if one eye is bulging out. And certainly if a patient has fully progressed disease, that may be the case. But early on, you're not going to notice that. But what you are going to notice is that they're going to develop dysconjugate gaze. Because as that patient looks to the extreme ends of their left or right sides of their vision, you're going to notice that one eye drags behind because that eye is being pushed forward. So it can't make it all the way to the one side or the other. What the patient's going to notice, because they're not looking in the mirror at the time they're doing this, is they're going to notice that when they look out of the corner of their eye, they're going to have double vision. And that can be the first sign that this patient may be developing an orbital pseudotumor. This patient has subglottic stenosis. This is the vocal cords up here, and you can see down here, this is the area where the subglottic stenosis occurs. This entire area should be wide open, but you can see it's been narrowed down to this pinpoint. And you can just imagine how hard it is to take a deep breath when that's what you're working with. This is a patient with GPA who has a pulmonary nodule as a result. This is a plain film, and this is what the CT scan looks like. And again, this could also be consistent with the aspergilloma. This could also be consistent with the new diagnosis of lung cancer. And in a patient who doesn't have an established diagnosis of GPA, you can't figure out what that mass is being caused by just based on the radiographic appearance alone. I want to give you another way to think about these diagnoses. So microscopic polyangiitis to a first approximation is a monophasic illness. And what that means is by the time they present, the worst things are already happening. These patients present when they already have renal failure or pulmonary hemorrhage or something else that's pretty serious enough generally to get them into a hospital setting, which is the reason why you so commonly meet these patients on the consult services. Now, GPA is really a biphasic illness, and what that means is that these patients will often initially present with the granulomatous manifestations. These patients will often have at least a few years of, say, sinus involvement or eustachian tube dysfunction, or maybe see these other symptoms like arthralgias or cutaneous manifestations. And it's only after that patient sits with those manifestations for a while that they start looking like the MPA patients with glomerulonephritis and pulmonary hemorrhage. Now, it's definitely true that some patients don't progress past that first stage. So some patients really only develop disease from the neck on up and never really develop that life-threatening manifestations that we think of with microscopic polyangiitis. So these patients are going to look different depending at what point in their disease you meet them. So if you meet them late in their disease course, they're going to look just like the MPA patients in terms of their disease manifestations. But if you meet them earlier, these patients may have relatively mild diagnosis. And the reason why it's so important to make an early diagnosis in these patients is if you meet a patient early on and you start immunosuppression up front, you may prevent that patient from developing the more severe manifestations that are associated with late disease. So MPA is a monophasic illness, GPA is a biphasic illness, and that brings us to EGPA, which can be thought of as a triphasic illness. So these patients started out with a diagnosis of adult onset asthma. So these patients are a picture of health until they hit their 30s or 40s, and for the first time in their life, they start to wheeze. And as they wheeze and they get short of breath, they find that eventually they're dependent on steroids in order to keep their airways open. So that's phase one. Phase two is the phase that's characterized by the presence of eosinophilic infiltrates. Most commonly, this is going to lead to those fleeting pulmonary infiltrates we mentioned before, but these patients can also develop myocarditis, urticarial lesions, gut involvement leading to eosinophilic esophagitis and eosinophilic colitis, and other manifestations depending on where the eosinophils tend to go. Finally, there's phase three. Phase three is the vasculitic phase that again looks just like microscopic polyangiitis. These are the patients who can develop glomerulonephritis and pulmonary hemorrhage, but most typically these patients are going to develop mononeuritis multiplex as their vasculitic manifestation. Now, just like GPA, it's true that patients don't always progress through all three phases, so you'll find that some patients just have a form fruits of this diagnosis. But again, it's believed that an early diagnosis is going to help keep these patients from progressing. And it's actually thought that our tendency to use so much steroids in patients who have bad asthma is one of the reasons why we don't see EGPA more often in our clinics. You got to give me credit for the fact that I think I've used the word ANCA about 10 times so far, and I haven't once tried to explain what an ANCA is. So let me do that now. So ANCA stands for anti-neutrophil cytoplasmic antibody, and it comes from this really cool observation made by two physicians named Jeanette and Falk from UNC Chapel Hill, who found that if you took serum from patients with idiopathic, rapidly progressive glomerulonephritis, and you tried to stain neutrophils with it, by and large, these patients' neutrophils would stain in one of two different staining patterns. Some patients would develop staining along the cytoplasm, and that would cause a C ANCA staining pattern. Some patients would develop staining around the periphery of the nucleus, and that would cause a P ANCA staining pattern. Later on, it was found that the C ANCA staining pattern was caused by antibodies against proteinase 3, or PR3 ANCA, and the P ANCA staining pattern was caused by antibodies against myeloperoxidase, or an MPO ANCA staining pattern. And the reason why this is interesting to you is because these patterns actually predict the diagnosis that you should be looking for. So if you see a C ANCA staining pattern, by and large, you're looking for granulomatosis with polyangiitis. Now, it is true that some patients with GPA will have a P ANCA staining pattern, but by and large, P ANCA correlates with the other two diagnoses, namely microscopic polyangiitis and eosinophilic granulomatosis with polyangiitis. Now, a full discussion of the significance of ANCA and the pathogenesis of ANCA-associated vasculitis will require a significant amount of alcohol that's probably not appropriate in the middle of the day. So let me just make a couple of points. The first is that you will run across a form of antibody that they refer to as an atypical ANCA. And the thing you should remember is that an atypical ANCA does not associate with ANCA-associated vasculitis. When you see the phrase atypical ANCA, what that means is the lab looks down and they see that there's neutrophil staining, but it doesn't look like it's either a P ANCA staining pattern or a C ANCA staining pattern. That definitely means the patient has some form of autoimmunity, but in the same way that an ANA positive 1 to 40 means the patient has some form of autoimmunity and doesn't necessarily point in the direction of any particular diagnosis. The second thing to remember is that ANCA titers do not predict disease flare. So as you manage these patients, you're going to see that people really want to recheck the ANCA to see how well the patient's doing. Please resist. ANCAs are very useful for establishing an initial diagnosis of vasculitis, but once you've made that diagnosis, following serial ANCA titers often isn't that helpful. The third point I'm going to make is that ANCAs tend to be positive in patients with active vasculitis. And the reason why I'm going to mention that is you'll read that up to 50% of patients with ANCA-associated vasculitis are going to be ANCA negative. And that's definitely true, but that's sort of a cross-sectional observation. On the other hand, if you're on a consult service and all you're seeing is very active patients with ANCA-associated vasculitis, multiple organs involved, never been treated with immunosuppression, typically those patients are going to be ANCA positive. So if those patients are ANCA negative, you might want to think just a little bit harder as to whether or not you've got the right diagnosis. Now, I told you before that patients with GPA could either be PR3 ANCA positive or MPO ANCA positive. And the thing to remember there, that PR3 ANCA positive patients are going to have a little bit worse disease. They're going to have more severe diagnoses. They're going to have diagnoses that are more likely to involve the kidneys, and they're more likely to relapse. The last thing I'm going to say about ANCA is specific to eGPA, that ANCA positivity can help predict the manifestations that you might associate in any given patient. So patients with eGPA who are ANCA positive, they're more likely to look like the other vasculitis patients. So those are the patients who are going to be presenting with, say, monorized multiplex or glomerulonephritis. The ANCA negative patients, those patients are a little bit more likely to behave like they've got an eosinophilic disorder. And those patients are going to be more likely to develop cardiopulmonary manifestations. Now, this division's not perfect, and certainly there's a lot of crossover between these two groups, but it's sort of interesting to think in terms of pathogenesis, how this distinction came about. Now let's talk a little bit about differential diagnosis. In order to do that, we're going to talk about this. So this is a Monet. And if you took an art history lesson in college, you'll know that this is a Monet, because you know that Monet, towards the end of his life, moved to Giverny, which is south of Paris, where he took up residence in an area with a pond with water lilies, and he spent the rest of his career painting these water lilies in progressively more abstract styles. Now that's if you're an MFA major. If you're like the rest of us, you know that it's a Monet because you know basically that Monet paints three things. He paints haystacks, churches, and water lilies. And with that model in mind, we're going to talk briefly about some of the other forms of vasculitis. So it's going to mention MPA briefly, causes pulmonary renal syndrome, is MPO ANCA positive. GPA causes granulomatous masses and is PR3 ANCA positive. eGPA associates with asthma and eosinophilia, and again is MPO ANCA positive. Urticarial vasculitis, not surprisingly, presents with urticaria, but these urticaria are different than most. They last for longer than 2 days. They tend to be painful rather than pruritic, and they heal with a bruise. IgA vasculitis tends to affect the skin, the joints, and the kidneys, roughly in that order. These patients can also develop gut involvement, which is classically described as colicky abdominal pain, just like you might have in a little kid. Finally, cryoglobuline vasculitis, you're going to want to think about in patients who've got untreated hepatitis C, but occasionally this will also come up in patients who've got a malignancy or another form of chronic infection. So let's say you see this patient and you're thinking to yourself that this patient probably has a small vessel vasculitis, but you're not 100% sure. I highly encourage you to get a skin biopsy just to confirm. Now, remember when you ask a dermatologist to get a skin biopsy, you're basically asking them to do two separate tests. You're asking them for H&E and you're asking them for immunofluorescence. Now, the H&E is just the morphology. Is there evidence of blood vessel destruction? Now, what you're hoping to see is things like fibrinoid necrosis and diapedesis, but what you might see instead is something called perivascular cuffing. That just means that there are inflammatory cells in the region of the blood vessel, but not necessarily evidence that the immune system is attacking that particular blood vessel. And that's the reason why immunofluorescence can be so helpful, because the immunofluorescence will often show you whether the blood vessel itself is the immunologic target of that process. It can also help you narrow down the diagnosis you should be looking for. So if you see IgA deposition, again, not surprisingly, you're thinking about IgA vasculitis or Henoch-Schönlein purpura. If you see a full house deposition pattern, so you see basically all the immunoreactants simultaneously, you're going to think about lupus. If it's pauciimmune, you don't see any immunoreactants or you just see +1 staining of some immunoreactants, you're going to think about an ANCA-associated vasculitis. Finally, if you see IgM and C3 deposition and you are taking a board examination, you're going to think about cryoglobuline vasculitis. If you see IgM and C3 deposition and you're in clinic, you're going to know that cryo is one consideration, but basically all the other forms of small vessel vasculitis can also be associated with IgM and C3 deposition. Now, when you ask for a biopsy, just keep a couple of things in mind. The first is that you want to biopsy the freshest lesion. Instinctually, you're going to want to biopsy the most interesting lesion, the largest lesion, the lesion that seems to be there for the longest period of time, but that lesion is most likely to be fibrotic. So those biopsies are going to be the least informative. The other thing I wanted to point out is that the immunofluorescence can be altered by the presence of immunosuppression. So if you see that patient and you start them in immunosuppression, and 2 weeks later is when you get the biopsy done, you might find that the immunofluorescence pattern is not reliable. It's not a reason not to treat that patient, but something to keep in mind when you're interpreting these tests. Now, because I'm talking about skin biopsies, let me talk about biopsies in general. If a patient presents with vasculitis affecting 6 different organs and one of them is the skin, we'll probably go after the skin in terms of biopsy, not because the skin's any better than anything else, but just because it's more accessible and it's relatively easy to do a skin biopsy. I love kidney biopsies, and if your patient has an active sediment or any hint of glomerulonephritis, I will likely ask the nephrologist to consider a kidney biopsy, because not only does it establish the diagnosis, it helps predict prognosis, because based on the characteristics of that biopsy, I can predict the likelihood of kidney recovery, and from that I can figure out how aggressively I should pursue immunosuppression. In the same way I love kidney biopsies, I hate nerve biopsies, and it's because the yield is pretty low. I would say that neurologists probably think differently about these patients because they often see patients with isolated nerve involvement where they really don't know if it's vasculitic or not. For our patients who present with syndromes that might include the nerves, often there's enough evidence to establish a diagnosis of vasculitis that you don't need the proof that the nerve itself is vasculitic before you start immunosuppressive therapy. With regards to biopsy of other organs, often it's more useful for ruling out other diagnoses than it is ruling in vasculitis. I'll mention that sinus biopsies for GPA have a yield of about 30%, so not great. The other thing I'll mention that if you're thinking about doing a lung biopsy, remember that you generally need architecture. So for most of these patients, if you're trying to establish a diagnosis based on a lung biopsy, you're going to have to do an open lung biopsy or a VATS. So let's say you see a patient like the one that we started describing in the first part of this talk, and all they seem to have is a cutaneous vasculitis. You go through the complete review of systems with them, nothing else seems to be involved. So what do you do with those patients? Well, the first thing to keep in mind is that there are many causes of cutaneous vasculitis, and about half the cases you're going to do the $1 million workup, and you're still not going to know why that patient has skin vasculitis. And I often point that out to patients before I start testing. About 10% of cases are going to be related to drugs, which is important to keep in mind. And the other can be related to a whole host of conditions, many of which can be the early manifestations of something that might develop into another diagnosis that's much more interesting. Because there are so many diagnoses that can be associated with cutaneous vasculitis, the history and physical is really key to figuring out what diagnoses you should be thinking about. The other thing I'm going to mention is that sometimes cutaneous vasculitis can be self-limited. So if a patient just developed a cutaneous vasculitis yesterday, sometimes you're just going to want to see what it develops into before you get too excited in terms of the evaluation. Remember that basically any drug can cause a cutaneous vasculitis. Antibiotics are always at the top of the list, but there are very few drugs that are spared. I did want to mention specifically PTO and minocycline that can cause a drug-induced ANCA-associated vasculitis. So these patients will present not only with the cutaneous manifestations, but pretty high ANCA titers. So in these patients' cases, the first thing to do is just to stop the drug. In terms of laboratory evaluation, the one thing that I always do for my patients is I always get a urinalysis, because the one thing that I lose sleep over is the possibility that I'm missing a vasculitis that might be affecting the kidneys. So urinalysis can be very reassuring with that regard. In the same way, I'll often get an ESR and a C-reactive protein, because if they have a lot of inflammation systemically, I might do a more thorough evaluation in terms of other causes. I put ANCA in brackets because I'm not recommending that you get an ANCA test, but by that time that patient gets to you, someone else has already ordered the ANCA. So part of your job now is going to be explaining away ANCA tests that don't necessarily make any sense for your particular patient. And the rest of these things are things to consider in specific cases. A patient who's got a lot of inflammation in admission setting, you want to think about endocarditis. I put serum cryoglobulins in brackets because the cryo test is so hard to run, it's often going to be a false negative, but rheumatoid factor is often positive in patients who've got cryoglobulin vasculitis. In older patients, you're going to think about a monoclonal gammopathy as a cause of cutaneous vasculitis. And in patients in general, I think about lupus, again, not because lupus is the most common cause of a leukocytoclastic vasculitis in the skin, but lupus is just so common in general. I don't think it's ever wrong to think about lupus. You're going to want to think about chronic viral infections and even acute viral infections in some cases. I put these diagnoses in brackets because these are some of the diagnoses that lead to those transient leukocytoclastic vasculitis presentations that you might see in clinic. And if I think that a patient's been exposed recently to a kid who's got one of these diagnoses, I might just tell them to wait for a few weeks and see what happens. This is my reminder to tell you that morphology is not a reliable way to establish a diagnosis of leukocytoclastic vasculitis. So this patient has sort of a unique form of purpura. You can see here there are blebs. There are sort of these plaque-like lesions down here. On biopsy, though, it's going to show leukocytoclastic vasculitis, and you can't determine, based on the morphology, what diagnoses of the ones that I listed is the most likely. So in all these cases, you basically have to do the same evaluation. In terms of treatment, remember that the goal is to use the least toxic treatment possible in order to accomplish your main goals, which is to get the diagnosis under control and to keep it from coming back. So the general approach is going to be using glucocorticoids at some dose, plus a steroid-sparing agent. So how do you choose what dose of steroids to use and what steroid-sparing agent to use? And the general rule of thumb is to let the punishment fit the crime. So let's say you have a life-threatening diagnosis, like a severe diagnosis of vasculitis. So typically these patients are going to be treated aggressively, and classically that's going to mean cyclophosphamide and pulse steroid therapy. That said, I will say that rituximab is often substituted, particularly for patients who have got an ANCA-associated vasculitis or cryoglobulinic vasculitis. Let's say a patient has minor disease or less severe disease. So a patient who's got limited disease or non-severe disease that is not life-threatening. For those patients, the main risk is the relapse. These patients are subject to having problems not only from the disease itself, but from being subjected to multiple courses of glucocorticoids. So these are patients where you might want to consider an antimetabolite. Most typically, that's going to be drugs like methotrexate, azathioprine, or mycophenolate mofetil. And finally, you're going to think about patients who have things like isolated cutaneous angeitis, so patients who just have palpable purpura and nothing else. Now, for those patients, steroids by themselves are probably enough, but if those patients are going to have recurrent disease, you might want to think about an immunomodulatory agent like dapsone or colchicine, which is milder than drugs like methotrexate or azathioprine, but still might be enough to get your patient under control. So let me just sum up. So remember that small vessel vasculitis is an umbrella term for many diagnoses that are characterized by inflammation of the capillaries, the arterioles, and the venules. Many of these diagnoses can present with specific signs and symptoms that can help you establish a diagnosis. And finally, treatment should be based on the severity of organ involvement. And if you'll indulge me for just one more slide, I just want to acknowledge all the fellows that I've helped train over the years. I want to thank them publicly for everything they've taught me and for all their support. And with that, I'll end. Thank you so much.
Wonderful. Thank you so much for that talk and for that wonderful acknowledgement slide towards the end. Lots of familiar names. We do have 2 questions in the chat. And I encourage other people, if you have any pressing questions, please feel free to type them in because we still have some time towards the end. So here's the 2 questions. The first is, apart from Behçet's and Cogan's being variable vessel vasculitides, can other connective tissue diseases like RA and the rest cause variable vessel vasculitis? Thank you.
So with regards to variable vessel vasculitis, the category is really most useful for those 2 diagnoses, Behçet and Cogan syndrome. I should mention that Cogan syndrome, only about 10% of cases actually have large vessel vasculitis. So even for Cogan's, it's not common to have multiple categories of blood vessels involved. I would say for other diagnoses, you'll probably find case reports of patients who have, say, large vessel manifestations that were attributed to rheumatoid arthritis, but it's not common enough that I would consider it on a regular basis.
Okay. And the second question is, unless we have other questions, it'll be the last question from the audience. In regards to Plex, apart from using it with associated anti-GBM antibody, do you recommend it in patients with DAH, given that DAH patients were underrepresented in the PEXIVAS trial? And at what point would you recommend using it with kidney disease / dialysis? So it's a twofer.
All right, I got to take a sip of tea. I'm going to give you a little bit of background just because we got a few minutes, and I think that this question may not make a lot of sense to some of you. So remember that by tradition, the way to deal with any severe illness is bloodletting. So that led to the practice of plasma exchange for patients with ANCA-associated vasculitis, which for many years was standard of care for patients who have the most severe manifestation, namely pulmonary hemorrhage and glomerulonephritis. There was a recently completed, very large, like basically the largest randomized clinical trial of ANCA-associated vasculitis that looked specifically at patients who had severe manifestations and looked at the effect of plasma exchange, and they couldn't find any results at all in terms of benefit. With regards to these specific questions, I will say that the times that clinically up till now I've been using plasma exchange is really less for the kidney patients and more for the patients who have pulmonary hemorrhage. And I think that although PEXIVAS was underpowered for the pulmonary hemorrhage question, there's also a separate study that came out of the Mayo Clinic that looked at the pulmonary hemorrhage patients and also failed to find an advantage. And there's also an unpublished meta-analysis that's looked at the patients with pulmonary hemorrhage in both the PEXIVAS study and in other studies, and furthermore failed to find an advantage to plasma exchange. So I think for the DAH question, plasma exchange is probably dead, except in a small number of cases where you really don't have a choice. I think with regards to glomerulonephritis, for patients who present with renal failure, so significantly elevated serum creatinine, a meta-analysis of the PEXIVAS trial and other clinical trials, including MEPEX, that have looked at plasma exchange for patients with severe kidney involvement, has demonstrated a benefit. I'll remind you that plasma exchange is not necessarily a completely benign therapy because of the catheter that's associated with an increased risk of infections. So it's not necessarily a treatment I jump for, but it certainly does seem to have benefit for patients who present with that particular scenario.
And we actually have like 6 more questions that just popped up. So this is in 2 minutes, so we'll quickly go through them. So what are your thoughts on the utility of the 5-factor score? When should we use them?
That's great. 5-factor score is an underloved, underappreciated thing. So you guys should Google this later. Basically, the 5-factor score is a prognostic score. So of the factors that are of interest, age greater than 65, gastrointestinal involvement, cardiovascular involvement, and one that I'm blanking on, cardiac involvement. And having one of those factors increases your 5-year mortality to 20%. So I think it's useful in terms of making a prognosis for a patient when that patient presents to you in clinic. It's not so useful in the way that you'd like it to be useful, that you'd like it to tell you what treatment to use. It doesn't do that, but it does tell you what the life expectancy of your patient might be and the probability of death in the next 5 years.
Awesome. Next question. How do you conceptualize and manage EGPA in relation with other hypereosinophilic syndromes like eosinophilic pneumonia?
That's a great question. And the answer is a couple of things. One is that patients ANCA positive, they have EGPA until proven otherwise. There's no such thing as ANCA positive idiopathic hypereosinophilic syndrome. The second is that chronic eosinophilic pneumonia is essentially identical to EGPA phase 2. And if you're faced with a patient like that, you should diagnose them with EGPA because EGPA is recognized by the FDA as an indication for mepolizumab, whereas chronic eosinophilic pneumonia is not. So your patient, in this very rare instance, will benefit from having a rheumatic diagnosis. For patients with the idiopathic hypereosinophilic syndromes, often they're going to have involvement that spares the lungs in terms of asthma. So asthma is really a characteristic of EGPA alone. If your patient is severely wheezing, that patient probably has EGPA and not one of the other hypereosinophilic syndromes.
I'm going to skip one question because it's similar to this. So do you typically add mepolizumab to all patients with EGPA?
Yeah, so mepolizumab is amazing for people who have got respiratory involvement. So if you think about patients who have got chronic asthma in particular, who traditionally would have been stuck on 10 milligrams of prednisone, it's an amazing drug. I think for the vasculitic manifestations, it's less clear. So if you have a patient who presents with monorized multiplex, you can give them mepolizumab, but I would certainly give them something else too.
I'm glad that your answer is the same as my answer as an allergist. Oftentimes, there's lots of big disagreements between the two specialties. I'm going to go through the other question, the one that I skipped. What are your, we have referrals from ENT for ANCA-negative, biopsy-negative chronic sinusitis to empirically treat as ANCA-negative limited GPA. How do you handle them with no other systemic features? That's in parentheses.
Yeah, that's a great question. And the answer is that first, I generally ask for a biopsy, which the ENTs are reluctant to do because they know the data as well as I do, that the biopsies are low yield. But if I'm being asked to treat someone who only has sinus involvement that I can't see physically, because I can't see that with my little otoscope when I look up their nose, I'll generally ask for a little bit more data to prove that they've got something inflammatory and non-infectious. Past that point, it's what they call shared decision making. I tell the patient that it's possible they've got this diagnosis. I will often offer them a limited course of methotrexate and steroids, and I'll reevaluate. If we feel like it's helped and there is evidence on ENT examinations that there's been improvement in the sinonasal mucosa, I'll continue therapy. But I always make it very clear to the patient that with clinical diagnoses, there's always a chance that we're getting something wrong.
As an immunologist, I feel obligated to mention, please make sure that you check for immunodeficiencies too, because it's often a mimic for these chronic sinusitis that they suspect autoimmune features. Two more questions, and we're running kind of a little over time, so I apologize. What are your thoughts on the addition of avacopan? Do you reserve it for patients with trouble tapering glucocorticoids or after rituximab or cyclophosphamide?
So the thing about avacopan is you would like to do exactly what you said. The problem is that avacopan's main benefit, it's got two benefits, probably one major, one minor. The main benefit is that it allows you to get them off of steroids really fast. So if you think about the way that we use steroids, the real benefit to that patient is going to be in the first month or two of therapy. So I think by that time, they have already been subjected to the main effects of the steroids. So by the time that you know that they failed treatment, they've already sort of lost out on one of the main benefits from avacopan. So if you have the ability to get it, I think you should start it early. With regards to the minor benefit, the really cool thing about avacopan that no one understands is if you entered the trial with some renal involvement, your rate of renal recovery was better if you got avacopan than if you just got steroids alone, even at the high traditional doses that we normally use. So it does imply for patients who've got renal involvement in particular, there might be a little bit of extra motivation to get them on avacopan.
Cool. And a new question popped up beyond that. So number one, oh goodness. So number one, is there anything characteristic to diagnose polyangiitis nodosa?
Anything specific. So unfortunately, it's more of a clinical diagnosis because it gets back to that concept of people are often very attached to their major arteries. So it's unless something tragic is happening to the patient and they need some sort of surgical intervention, you're often not going to have a biopsy of a blood vessel underneath the slide. Now, it's different for cutaneous polyarteritis nodosa. For those patients, the blood vessels that are involved are accessible, and you can often make a biopsy-proven diagnosis. But for someone with like mesenteric involvement, if you're trying to rule out polyarteritis nodosa versus, say, segmental arterial medial lysis, it's a clinical diagnosis. You just have to look at the data and make your best guess. Or send them to me.
And last question we have here, and then we have one comment beyond that, but last question is, if a patient with small vessel vasculitis with renal involvement develops abdominal pain, how will you proceed? Because imaging may be harmful due to renal impairment. And does it change the management plan?
I'm sorry, the internet signal went out for the first part of the question. Do you mind repeating that?
Sure, absolutely. So if a patient with small vessel vasculitis with renal involvement develops abdominal pain, how will you proceed? Because imaging may be harmful due to renal impairment. And does this change the management plan?
Well, it sort of depends on why they got abdominal pain. So the two scenarios I'm thinking about is someone who's got an IgA vasculitis or someone who's got a mesenteric uveitis from polyarteritis nodosa. If they've got IgA vasculitis, and I already know they have IgA vasculitis because I biopsied their skin, you could probably just treat them empirically with a course of steroids. I agree there's no particular role for imaging. And even if you did image, the caliber of the blood vessels is small enough that you wouldn't see anything. Now, if they had a medium vessel involvement, I would say that it's possible that a conventional angiography could be both diagnostic and therapeutic if someone has critical ischemia that needs to be opened up. As Dr. Grayson mentioned before, we do try to avoid procedures in these patients, but sometimes they have no choice. So I think that in a patient who doesn't have an established diagnosis of vasculitis, imaging can still be useful. I think when a patient already has an established diagnosis and they've got other contraindications against imaging, I agree it wouldn't necessarily be worthwhile.
Great. So that was our last question. One comment is thank you so much. Wonderful talk and wonderful moderation. And then I wanted to finish off by reminding you to do the two quick questions. Thank you very much, Dr. Seo and Dr. Grayson for this session and the previous session. And it's been my pleasure to moderate this. And thank you for so many wonderful questions that you guys have posted in the chat.
Thanks, everyone.
Take care.